Hi to everybody. It's really great to see you, or just about to see you. It's quite difficult to see with the lights on here. It's a real pleasure to come to this conference, I have to say, and such a pleasure to see people live and to get out of London. So it's just great to be here. As Paul says, I'm chair of the Royal College of GPs, which is the one of 29 Royal Colleges, medical Royal Colleges, and we represent 54,000 members, about 70% of doctors working in general practice, so quite a significant kind of reach in general practice. I'm also a GP. I've been a GP for 32 years now, and for the last 10 years I've been working in Newham in East London in a really interesting practice that brings together the old East End, which is very multicultural, very socioeconomically deprived, with the new East End, which is young professional couples working in the city and Canary Wharf. So it's a very diverse and interesting practice that I serve. And I'm also an academic with an interest in health service research, particularly the impact of changing the design and delivery of services on outcomes for patients. So that's my kind of background. I've also worked in government a little bit as well. So that's my background. Our college, the Royal College of GPs, is totally committed to end-of-life care. It's such an important part of what we do. And we do that through a whole range of different partnerships. We work very closely with Marie Curie, with Macmillan. We do a lot of CPD, a lot of standard setting, particularly the daffodil standards most recently. We do a lot of research in this area as well. So thoroughly committed. And the reason for that is the GP role in palliative care and end-of-life care is so important, and in many ways always has been, it seems to me. It's also growing as well. The proportion, the percentage of deaths that happens in hospitals, in care homes, has reduced over the last year as a consequence, I guess, of the pandemic. And the proportion of deaths that's happening at home is increasing. The latest figure that I've seen, it increased from 31% of deaths pre-pandemic to 41% of deaths happening at home now. As I say, that probably is the consequence of the pandemic. We know that a lot of people didn't want to go into hospital. Hospital beds were saved for sick COVID patients. A lot of people were worried about the risk of infection. A lot of people, of course, couldn't have family members with them, so they'd want to be at home where they were close to family. And a lot of family members, a lot of potential carers for people approaching the end of their life were maybe on furlough and maybe able to provide more care at home than perhaps they might have been able to do if they were full-time working. So I suspect, although what we're seeing at the moment, which in many ways is a reversal of a trend and a very welcome one, we know that more people wanted to die at home than were doing so. I suspect that's a trend which will continue, and we in general practice need to be ready for that. You in hospice movement need to be ready for that as well. During the pandemic, we've had to address some pretty difficult problems and some pretty complex problems. The availability of PPE, of personal protective equipment, if you remember, in the early days of the first wave of the pandemic, was a massive challenge to all of us. And of course, also some very big issues about advanced care planning. Some areas where it really wasn't done to any extent in the way that it should have been done. So we've had to address some really very significant issues during the last year. And in addition to the deaths, of course, we've got a massive issue around bereavement now. It's been estimated that 2.7 million people in the UK have experienced bereavement, and we need to be able to look after those people. Again, across a whole range of primary and community care services. And that's why our end-of-life care, Catherine Millington-Saunders, who's a true star, set up a bereavement task and finish group, and that's feeding into the government's commission on bereavement. So the general practice, it seems to me, has a really important role in this field, and it's a role which is going to grow in so many ways. But I'm not actually going to talk specifically about general practice's role in palliative care at the moment, because the title of this section is The Future of the Healthcare System Post-COVID. That's quite a big title and quite a big challenge, I must say. So I'm going to focus specifically on general practice, where general practice is now, and where general practice is going over the next 5, 10, 15, 20 years. I'm going to do that because I think that that will give us collectively some insights into what we need to do together between general practice and the hospice care sector in order to ensure that we continue to deliver high quality end-of-life care and we deliver better end-of-life care as we move into the future. When I'm talking about the state of general practice at the moment, I'm afraid you probably won't be surprised. You're going to hear a bit of a tale of woe, at least for the first part of my presentation. General practice is struggling at the moment, but I'm hoping that you'll also hear a tale of inspiration about where general practice is going as well. So let's step back a little bit and look at the take a historical perspective on general practice. This is a perspective which is still reflected in many people's view of what general practice is and what it's for. General practice has often been described as the jewel in the crown of the NHS. It's where you get cradle to grave care from somebody who you know and trust. People talk about my GP. And we've seen a long history of general practice delivering personal care and continuity of care. That might be a slightly rose-tinted view of where general practice has been historically, but it's not actually far off the mark. And general practice has played a fundamentally important role in the success of the NHS as a whole. General practice deals with 90% of the presentations that come to the NHS every day. That's over 1 million consultations a day. We deal with most of those without any recourse to other services. Most 90%, 92% of problems are dealt with purely in general practice. Only about 10% are referred on to other services. And we do all that for less than 10% of the total healthcare spend, which is one of the smallest percentages of spend going into primary care of any developed country. And general practice, therefore, is the reason that often people, until recently, at least until recent years, have talked about the NHS being one of the highest value healthcare systems in the world. And by that I mean the best outcomes for the lowest investment. So general practice is fundamentally important, but it's a long, long way from that ideal that I've described to you. We're in the middle of a crisis that's grown over probably a decade. It's been made worse by the pandemic, but it hasn't been caused by the pandemic. This is a crisis which has grown and grown, and in many ways it's not really come to the public's notice until recently, primarily because general practice is very good at just flexing and absorbing the asks that are made of it. But it's reached a point where it just can't flex and can't absorb anymore. And people are noticing, patients are noticing in terms of their ability to access their GP. Patients are noticing in terms of the time that GPs have to give to their patients when they do eventually get to see them or speak to them on the telephone. Clinicians are noticing as well some really difficult statistics. 60% of GPs say that their mental health has deteriorated over the last 18 months. 34% of GPs say that at least once a week they panic that they just can't do their job. And 35% of GPs say that they're going to retire in the next 5 years. That would be 14,000 fewer GPs than we've got at the moment, nearly 3,000 a year that we would be losing. And these are experienced GPs that are currently delivering a massive service. So we've got a very significant crisis, and at the heart of the crisis is it's about workload. That's primarily what we're having to deal with now. And that's reflected in a range of ways. The number of consultations, so we know that the number of consultations has gone up year on year for the last decade at least. If I personalise that, when I started as a GP, I was a partner in Exeter in Devon for the first decade or so of my career. And on a busy day, I'd probably see 20 to 22 patients. Now in East London, on a busy day, I'm seeing between 50 and 60 patients. It's really difficult to provide the same quality of care for my 50th patient as it is for my 5th patient in a day. And that's causing real significant problems. But it's not just about the number of consultations, it's also about the complexity of those consultations. In an average, the average consultation length in British general practice, which is one of the shortest in Europe, is 9.8 minutes. And in those 9.8 minutes, on average, patients bring 3 problems. Often all 3 of those are complex problems. So we're trying to deal with really difficult stuff, often in 2 to 3 minutes per problem. So there's an increased number, increased complexity, also lots of other activities that we're doing. A decade ago, we weren't doing mass vaccination programs except for children. Now we've got the flu vaccination program, and of course, most recently, a massive contribution to the COVID vaccination program. And a lot of the activities that used to be done in hospitals are now being passed out into the community. The work is being passed out, but not necessarily the resources. So what that's caused is a very significant challenge for general practice. So there's the problem. It's an easy problem to describe. The solution isn't quite so easy, unfortunately. There's no silver bullet that will help us to turn general practice around from the situation that it's in at the moment. But as a college, we're working very hard with a range of partners, including with government, in order to try to find solutions. And essentially, there's 3 solutions to the crisis that we're going through at the moment. One of them is a larger workforce, both doctors and other health professionals that are working in primary care. The second is working differently. How do we get greatest efficiency out of the workforce and the ways of working that we have? And the third is changing the way that patients think about how they use health services, what you might call their help-seeking behaviour. Difficult to say how much, but a significant proportion of problems that patients bring to general practice, they don't know, but probably didn't need to come to general practice in the first place. So how do you help them to make the best use of self-care, of available community services like pharmacies, without necessarily accessing professionalised services straight away? Of those 3 solutions, a larger workforce working differently and changing help-seeking behaviour, the most significant by a long, long way is a larger workforce. So in many ways, this is a simple problem. We've seen demand grow, and we haven't seen supply grow. The number of GPs that we have now is actually fewer in terms of full-time equivalents than we had in 2019, when the government committed to a significant expansion in the GP workforce, and fewer than we had in 2015, about 8% fewer than we had in 2015, when the same government also committed to an expansion in the GP workforce. So the workforce isn't big enough, and that's a consequence of both problems in the past with recruitment and problems now with retention. The recruitment issue is probably less of a problem than it used to be. So we are training more GPs, we've got more training places. Those training places are 100% full across the country. So in many ways there's been an investment, and general practice actually remains a very popular specialty choice of career for people coming out of medical school. So recruitment is less of a problem, retention remains a massive problem. And that's a problem not just at the end of the people's career. It's not just a question of people retiring early, which, as I gave the stat earlier, a significant proportion are threatening to do, but it's a consequence of more and more people working part-time. So when I started working in general practice, it was quite rare not to be a full-time GP unless you had caring responsibilities. But by 2016, what we call the participation rate, the proportion of time that people work, had dropped down to about 85%, and now it's about 65%. So the vast majority of GPs are working pretty part-time, and that's across the age ranges. It's not just middle-aged doctors. Young people are coming into general practice, they're looking at the workload, they're saying, actually, this looks like an exciting job, but it doesn't look like a doable job to do full-time. So more and more people are working, even at the beginning of their career, are working part-time. And some people are even saying when they get into general practice, I don't really want to study medicine anymore. I don't want to practice like this. I'm not able to do what I was trained to do as a doctor. And probably most worryingly, we're seeing a growing number of bright young doctors who are just leaving medicine and going to work somewhere else as a consequence. So that's a real challenge. So, as I say, the consequence is that increasingly we find ourselves in a place where we're not able to do, A, what we're trained to do, but most importantly, what we know our patients want and need. And this has a consequence for everything we do. including a consequence for our palliative care responsibilities. Now, I hope, and from what I see, there isn't any evidence of a deterioration in care around palliative care. I think every colleague that I've ever spoken to has always said, of all the things that might deteriorate, the last thing you want to do is give someone a bad experience at the end of their life. So GPs and their teams are going out of their way in order to produce as good quality care as possible, but it's going to struggle. It can't go on like this. So there's my tale of woe. I'm sorry about that. It was quite woeful, wasn't it, really? General practice is going through a difficult time. Let me try a little bit of hope and a little bit of inspiration as to where general practice might go. General practice is responding in a range of ways in terms of adapting its model, changing the way it thinks about how it delivers care and how it works as part of a wider healthcare system. And that's happening in a number of different areas. The first one, and probably the most obvious one to many people, is just an increase in scale. So when I first qualified, the average practice had about 3 doctors, maybe 6,000 patients. Now the average size is about 6 doctors and about 13 or 14,000 patients. But we see lots of practices where small practices have come together or large practices have just grown that might be serving 20, 30, 40, 50,000 patients. Some of those are networks of practices working together. Some of them are single organisations, a range of different governance mechanisms. Some of them are very much NHS practices. Some of them are owned by big multinationals with shareholders like Virgin, for example. So there's lots of different models, but fundamentally the size of general practice is getting bigger and bigger. Now, is that a good thing or a bad thing? I think if the front end of general practice, the bit of general practice that patients perceive and experience, is small and local, then it's okay, because that's what general practice needs to be. It needs to be seen and felt to be small and local for the patients and the communities that we serve. But the problem with that model is you have no infrastructure to support you. And I talk to a lot of doctors who say, sometimes I wouldn't mind going back into hospital where you've got an HR department, you've got a good education program, you've got good research, you've got good data, you've got good quality improvement. There's something about scale that gives you an infrastructure which we've never had in general practice. But general practices working at scale are starting to develop exactly that kind of infrastructure, an infrastructure that will allow us to do better things, to provide better care for our patients. So actually, I think the increase in scale, as long as we keep that front end local and small, I think the increase in scale is actually a good thing. And the mantra that we use is you've got to get big in order to stay small. And I think that's probably about right. So increase in scale is one of the changes. The second change is increase in multidisciplinarity. 30 years ago, about 85 or 90% of all consultations in general practice were delivered by GPs, and the rest were delivered mostly by practice nurses. And now it's only 45% are delivered by doctors, and the rest are delivered by an increasingly large multidisciplinary team, including still nurses, but pharmacists, physician associates, musculoskeletal experts, mental health experts, health coaches, a whole range of different health professional groups which are coming together. And by and large, they're delivering, I think, a higher quality service for patients. Not just because they bring a different set of skills, and in particular a different model. There's something GPs who work to a medical model. Having people working to other models, particularly a biopsychosocial model, I think is really exciting and really important. So for that reason it's good, but also there's pragmatic reasons as well. If you can't recruit GPs, and that's a problem that we've been having over the last decade or more, then other health professionals need to fill those gaps. So I think the trend towards multidisciplinarity in general practice is both a pragmatic thing and probably a good thing as far as patient care is concerned. And what's that doing? What the multidisciplinarity is doing in general practice is encouraging doctors, my colleagues, GPs, to think differently about what their role is. So rather than being all things to all people, which is what the traditional model of general practice was, GPs are saying, now where do I add value as part of a team, a member? And I think if you look at GPs, there's certain things that we're really good at. One of them is triage, making quick decisions based on risk, managing uncertainty, deciding whether someone's sick or not sick, whether they need care, what kind of care they need. That's something that we're trained to do really well and really quickly, and we just absorb that risk. So that's one area. And then the other area is the other end of the spectrum. We're trained to provide care for complex problems. People who've got multiple conditions, multimorbidity, people who've got biopsychosocial problems and require holistic care. So it's probably the two ends of the spectrum of what we used to do as general practice, where general GPs can add real value. And the large part of relatively straightforward, relatively guideline-orientated, relatively transactional stuff can often be done as well or often better by other members of the primary care team. So I think that shift in the way that doctors are working and shift in the way the whole team is working is again an exciting shift and a good shift for general practice. The third change won't come as any surprise to you, and that's increase in use of technology. General practice was probably the first part of the NHS to get into computer records. One of my neighbouring practices, when I worked in Devon, introduced paperless records in 1974, well ahead of, indeed there are many hospitals that still aren't paperless. But other use of technology to provide care is something that the NHS has been pretty slow to do, but that's changing really rapidly, again largely as a consequence of the pandemic. So we're seeing increasing use of technology for triage, for that decision-making process, often a remote process that allows patients almost to direct themselves to the right service. We're seeing increasing use of triage, technology for consulting. Interestingly, the most common technology is the telephone. It's a technology that's been around for 150 years, but increasingly we're using text-based and video-based consulting as well. That, you won't be surprised to hear, has been a big controversial issue in government. We're currently having some real ding-dongs with politicians in the Daily Mail about the balance between face-to-face and remote care, and I'd be very happy to have a conversation about that as part of our Q&A. But it seems to me that if we did 80% of consultations face-to-face before the pandemic, and now it's about 60% of consultations face-to-face, and during that time we discovered how much we can do remotely, how some of general practice can be delivered remotely in a more cost-effective and more convenient way for patients, then probably that's about right. So we're pushing back a lot on the Daily Mail, even though we understand some patients would like things to go back to how they were. So greater use of technology for consulting, greater use of technology for remote monitoring. Increasingly, our patients who are at home will have their physiological stats monitored, including pulse, blood pressure, oxygen saturation. If they're diabetic, their blood sugars. There's a lot of things that we can do and are starting to do, particularly around the hospital at home programme, which allow us to monitor closely at home and provide better quality care. And then the final area where technology is being used is in our interaction with specialist services over referrals. And I've done a number of really interesting referrals recently, which have ended up with a three-way video consultation between a patient, myself, and a consultant. It's an opportunity to provide really good care, to provide a team approach, and for all of us to learn together. So there's lots of ways in which technology, I think, is changing general practice, and as technology gets better, particularly we just need better computers and better broadband speeds in general practice, but as it gets better, we'll be using technology more. So that's the third change. The fourth change is, I think, an increase in the patient-centeredness of general practice, although I'm going to say this in a slightly mixed way. So general practice has never been the place where doctors know best. It's always been the place where we've recognised there's a medical expert and a patient expert, and you've got to bring that expertise together. But increasingly, we're going through a much more formal process of shared decision-making in the consultation. Shared decision-making based on data, that you can present data and say, people like you have got this chance of this outcome if you choose this particular option. That, to me, is really exciting. It's changing the way that we practice medicine in a way that is empowering a lot of patients who want to be empowered. So shared decision-making, I think, is really shifting the nature of medical practice in a very positive way, which I think is really exciting. The fifth area is a shift in orientation. General practice, traditionally, we teach, has got three different approaches. One of them is a disease-based, a biomedical approach. One of them is a person-centered, whole-person approach, the psychosocial approach. And the third one is a public health approach, the population health approach. And the first two of those models are ones that I think general practice has always engaged with and done well. But the population or community health approach is one that a small number of practices do well, but most practices actually don't. And increasingly, as a consequence of the pandemic, we're seeing growing numbers of practices that are really getting into the space where they're looking at the social determinants of health, they're looking at social interventions, social prescribing, they're looking at health inequalities, they're looking at the assets that exist in communities, and they're using those assets and that social determinant understanding in order to provide better care. Classic example of this is a patient that I look after in my practice in East London, a guy who I'll call Mohammed. He's in his early 40s. He's a refugee from Iran. He's here with his wife and two young daughters. He's been here for about 10 years now, something like that. And he was obese and he had type 2 diabetes. We've got a very high prevalence of diabetes in our population in East London. And over probably a year or 2 year period, I was struggling to manage his diabetes. Everything that I tried to do in terms of the stuff I'm trained to do as a doctor was having no impact whatsoever on his diabetic outcome. And it was only after about 18 months that he started trusting me, getting used to me, and started opening up to me. And I discovered that he lived in a 2-bedroom apartment with 17 other people. They had just 2 bedrooms, 4 beds, and they used to hot bed, 4 hours in bed, 4 hours out of bed. They had no kitchen, so they couldn't cook, and he ate all of his meals with his family in the local fried chicken shop. There's a lot of fried chicken shops in East London, for those who don't know. My favourite stat is there's 47 fried chicken shops per secondary school in our part of East London. So that's where he went, and he wasn't sad about that. He didn't think it was bad. In fact, he loved it. He loved fried chicken and chips. It was very cheap. He could have 2 big meals, filling meals for about £4, £4.50 a day. And he also found the fried chicken shop a place of quietness after his overcrowded house. He used to go there in order to meet his friends and just get a bit of peace. So understanding that completely changed my orientation as a doctor. Rather than adjusting his oral hypoglycemics or getting him onto insulin, I work with our social prescribing advisor, our link worker, in order to do a number of things. And this link worker is the most brilliant young psychology graduate, totally passionate and totally focused. And within 6 months, she'd managed to get him and his family rehoused into a 2-bedroom house. Within 9 months, she'd managed to get him some part-time employment, which gave him a sense of pride, a bit of extra income. We referred him, we've got a lot of referral schemes in East London, social referral schemes. We referred him to an exercise on prescription scheme. It's really good doing exercise on prescription in East London where I work because we use the Olympic facilities. So we can go to the Olympic swimming pool and the copper box and the velodrome in order to do exercise. We referred him to a cooking on prescription scheme which he attended with his wife, which taught him how to go to the market and buy green vegetables and cook vegetables. And over a period of time, I'm not claiming any magical miracle answer, but over a period of time, his diabetes improved, his weight reduced, he had a sense of pride, ability to look after his family, and that was all a consequence of a social intervention. And a social intervention, which he told me afterwards was a product of me and the team working with him closely and him trusting us in order to improve his care. And that's a kind of story that you hear across the country of people getting out of the medical model and into the wider whole person biopsychosocial model and delivering better care as a consequence of that. And then the final area which Paul touched upon earlier, you heard about this morning, is the better integration of the health service. The health service was designed in 1948 in 3 silos. There was a general practice silo, a hospital silo, and a community services silo. And by and large, it still operates in those silos 70, whatever it is, 3 years later. Increasingly, we're seeing much better integration between different parts of the health service, particularly between primary and community care and hospitals, but also between primary care and social care. And I'm not an uncommitted fan of the health and care bill, but at least it gives us an opportunity to start having different kind of conversations about what integrated care means for patients and how we reduce the fragmentation of the service. So there's 6 changes that I've described in general practice, all of which are either having an impact now on the care that we're able to provide or have the potential to have an impact on better care for patients, including better end-of-life care and palliative care. And each of those changes has got advantages for our end-of-life care. It's got some risks as well. The advantage of increased scale is a wider infrastructure to support care, to improve care. The advantage of a multidisciplinary team is a wider set of skills to support patients. The advantage of greater technology is the ability to be able to deliver more accessible care for patients. So there's a lot of advantages as well as one or two risks. But it seems to me that whilst the present is distinctly challenging in general practice, and whilst we desperately need greater investment, particularly a larger workforce, in order to be able to deliver the job that we are trained to deliver and we want to deliver for our patients, that actually the future along the kind of lines that I've described looks pretty positive to me. So thank you so much for listening, and I'm really keen to hear your questions, and in particular how what I've been talking about changes in the health system will impact on your roles in end-of-life care. Thank you.